Topic for today are the drugs that weaken the bacterial cell wall, the penicillins. Penicillins weaken the cell wall, causing bacteria to take up excessive amounts of water and rupture. As a result, penicillins are generally bactericidal. Penicillins weaken the cell wall by two actions: inhibition of transpeptidases and disinhibition of autolysins. Transpeptidases are enzymes critical to cell wall synthesis, while your autolysins are bacterial enzymes that leave bonds in the cell wall. So bacteria employ these enzymes to break down segments of the cell wall to permit growth and division. The molecular targets of the penicillins are known collectively as penicillin-binding proteins. These molecules are so named because penicillin must bind to them to produce antibacterial effects. PBPs, or your penicillin-binding proteins, are located on the outer surface of the cytoplasmic membrane. The drugs work only when bacteria are growing, and it have virtually no direct effects on cells of the host. And now for the mechanisms of bacterial resistance. So bacterial resistance to penicillins is determined primarily by three factors. First is your inability of penicillins to reach their targets. So all bacteria are surrounded by cell wall envelope. However, the cell envelope of gram-negative organisms differs from that of gram-positive organisms. So like the gram-positive cell wall, the gram-negative cell wall can be easily penetrated by penicillins. The outer membrane, however, is difficult to penetrate. As a result, only certain penicillins, example your ampicillins, are able to cross it and thereby reach the PBPs, or your penicillin-binding proteins, on the cytoplasmic membrane. Second would be your inactivation of penicillins by bacterial enzymes. So your beta-lactamases are enzymes that cleave the beta-lactam ring and thereby render penicillins and other beta-lactam antibiotics inactive. So your beta-lactamases that act selectively on penicillins are known as penicillinases. Third will be the production of BPPs that have low affinity for penicillins. So your methicillin-resistant Staphylococcus aureus, or your MRSA, have a unique mechanism of resistance, that is, production of BPPs with a low affinity for penicillins and almost all other beta-lactam antibiotics. So your MRSA developed this ability by acquiring genes that code for low affinity PBPs, or your penicillin-binding proteins, from the other bacteria. So we have here the classes of your penicillins. First is your narrow-spectrum penicillin, your penicillinase sensitive. Example will be your penicillin G and penicillin V, which has antimicrobial spectrum covering your Staphylococcus species, Neisseria species, and many anaerobes. Second will be your penicillinase resistant, or your anti-staphylococcal penicillin. We have here your nafcillin, oxacillin, and dicloxacillin, which is effective for your Staphylococcus aureus. We also have your aminopenicillins. We have your ampicillin and amoxicillin, useful for your infection for Haemophilus influenzae, Escherichia coli, Proteus mirabilis, Enterococci, and your Neisseria gonorrhoeae. And we also have your anti-Pseudomonas penicillin. Example will be your piperazillin. The antimicrobial spectrum covers same as broad-spectrum penicillin plus your Pseudomonas aeruginosa, Enterobacter species, Proteus, Bacteroides fragilis, and many Klebsiella. So your penicillin G, or your benzyl penicillin, was the first penicillin available and will serve as our prototype for the penicillin family. So this drug is often referred to simply as penicillin. They have gram-positive bacteria spectrum coverage except penicillinase producing staphylococci. It also covers your gram-negative cocci, such as your Neisseria meningitidis and non-penicillinase producing strains of Neisseria gonorrhoeae, and also covers your anaerobic bacteria. And your spirochetes, including your Treponema pallidum, is also covered by your penicillin G. The therapeutic uses of your penicillin G. Pen-G is a drug of choice for pharyngitis caused by your Streptococcus pyogenes and for infectious endocarditis caused by your Streptococcus viridans. So it is also used for your gas gangrene caused by your Clostridium perfringens and for your anthrax caused by your Bacillus anthracis. It is also the drug of choice for syphilis, which is an infection caused by your spirochete Treponema pallidum, and prevents syphilis in sexual partners. And it is also used as prophylaxis against recurrent attacks of rheumatic fever and for those with clear evidence of rheumatic heart disease. So your pharmacokinetics, um, we have here your potassium penicillin G, procaine penicillin G, benzathine penicillin G, and sodium penicillin G. So your absorption of potassium and sodium penicillin G is rapid, and the blood levels peak about 15 minutes after injection. In contrast, your procaine and your benzathine salts are absorbed slowly and hence considered as repository preparations. So penicillin undergoes minimal metabolism and is eliminated by the kidneys primarily as the unchanged drug. So your penicillins, they are the most common cause of drug allergy. No, so around 0.4 and 7% of patients who receive penicillins experience an allergic reaction. The severity can range from a minor rash to life-threatening anaphylaxis. So, if the allergy is mild, a cephalosporin is often an appropriate alternative. If, however, there is a history of anaphylaxis, it is prudent to avoid cephalosporins as well because there is about 1% of cross-sensitivity to cephalosporins. So, when a cephalosporin is indicated, an oral cephalosporin is preferred. Now, for many infections, vancomycin, erythromycin, and clindamycin are effective and safe alternatives for patients with penicillin allergy. Now, for the drug interactions, unfortunately, when penicillins are present in high concentration, they interact chemically with aminoglycosides and thereby inactivate the aminoglycoside. Accordingly, your penicillins and aminoglycosides should never be mixed with the same IV solution. Now, your probenecid can delay renal excretion of penicillin, thereby prolonging the antibacterial effects of your penicillin. Now, let's go for your penicillin V. So, penicillin V is also known as your penicillin VK, similar to your penicillin G in most respects. The principal difference is acid stability. So, your penicillin V is stable in stomach acid, whereas your penicillin G is not. So, it can be taken with meals, and because of its acid stability, your penicillin V has replaced your penicillin G for oral therapy. We also have your penicillinase resistant penicillins or your anti-staphylococcal penicillins. They are against penicillinase producing strains of your staphylococci. Since most strains of staphylococci produce penicillinase, the penicillinase-resistant penicillins are the drug of choice for the majority of staphylococcal infections. And we also have your aminopenicillins or your broad-spectrum penicillin. So your ampicillin was the first broad-spectrum penicillin in clinical use. The drug is used against infections caused by your Enterococcus faecalis, Proteus mirabilis, Escherichia coli, Salmonella, Shigella, and Haemophilus influenza. The most common side effects are rash and diarrhea, both of which occur more frequently with ampicillin than with any other penicillin. We also have your amoxicillin. It is similar to ampicillin in structure and actions. So the drugs differ primarily in acid stability and amoxicillin being the more acid stable. Now let's go for your anti-Pseudomonas penicillin or your extended spectrum penicillin. So only one extended spectrum penicillin is available. That is your piperacillin. So the antimicrobial spectrum of this drug includes your Pseudomonas aeruginosa, Enterobacter species, Proteus, Bacteroides fragilis, and many Klebsiella. Piperacillin is susceptible to beta-lactamases, and hence it is ineffective against most strains of your Staphylococcus aureus. So, penicillins combined with a beta-lactamase inhibitor, so as their name indicates, beta-lactamase inhibitors are drugs that inhibit your bacterial beta-lactamases. So, by combining a beta-lactamase inhibitor with a penicillinase-sensitive penicillin, we can extend the antimicrobial spectrum of the penicillin. Example are your ampicillin sulbactam, amoxicillin clavulanate, and your piperazillin tazobactam. Here are the dosages for your penicillins. So we have here for your penicillinase sensitive, penicillinase resistant, aminopenicillins, and your anti-pseudomonal penicillins. And that's it for your penicillins. Thank you for listening.